Everyone. My name is Michael Hellman, and this is my article presentation for exercise, health, and chronic disease prevention. My article is titled Cardiovascular Exercise and Burden of Arrhythmia in Patients with Atrial Fibrillation, a randomized controlled trial. The basis of the article's argument is that physical activity at moderate to high intensity is recommended to prevent lifestyle diseases. Atrial fibrillation, commonly referred to as AFib, causes people to be forced into a sedentary lifestyle due to fear of cardiac episodes. However, this article attempts to explain through a controlled trial how the pain and discomfort that arrhythmia causes can be reduced with physical exercise. First, atrial fibrillation is the most common cardiac rhythm disturbance in the Western world, affecting about 2% of the general population. A sedentary lifestyle increases the risk of cardiovascular disease, hypertension, diabetes, and obesity, which are all risk factors for AFib. The latest meta-analysis concerning health benefits of physical exercise for patients with all types of AFib. Exercise led to improvements in frequency control, lower risk of AFib relapse after ablation, and increased quality of life. This study's objective is to compare the effects of high-intensity cardiovascular training versus low-intensity cardiovascular training on AFib during a 12-week trial. The hypothesis was that high-intensity exercise would have more of a positive impact than low-intensity exercise. The study was an assessor-blinded, randomized, controlled superiority trial in which 76 different patients were assigned a 1-to-1 ratio to a 12-week program of physical exercise at low intensity or high intensity. Assessments were performed before first exercise session, which determines the baseline, and after 12 weeks, which is the follow-up. Throughout week 4 to 16, patients transmitted an electrocardiography twice daily and in case of AFib symptoms. Possible eligible patients were found by screening lists of admissions from the cardiology ward and the cardiology outpatient clinics at the two hospitals. Eligibility criteria were admission with International Classification of Disease. Inclusion criteria were paroxysmal or persistent AFib, documented on ECG, age 18 years and above, and written informed consent. After stratification for gender, patients were randomly assigned 1-to-1 ratio to either low intensity or high intensity exercise. To ensure concealment, randomization was generated by an employee at the hospital with no connection to the trial. All assessors and analysts were blinded to the intervention allocation. Patients were blinded to the study hypothesis, and they were not informed of what intervention they were receiving. Also, they were informed not to reveal any detail about their exercise group when performing follow-up tests to preserve blinding of the research team. Over 12 weeks, supervised exercise sessions of 60 minutes each were conducted twice weekly at various locations. To ensure close supervision of the patients during exercise, the participants were subdivided into small groups of 10 patients, exercising with one physiotherapist. Exercise was planned by experienced cardiac rehabilitation physiotherapists. Intensity was measured on the Borg scale, which is the rating of perceived exertion from 1 to 20, to adjust for individual physical improvement and to avoid using heart rate as measured scale. Borg 20 scale is valid for measuring exercise intensity and ensures standardization of the exercise program so each individual exercise at the same relative intensity. Assessing exercise intensity with heart rate could be inaccurate in patients receiving medical frequency control or in case a patient had AFib during exercise. Low intensity exercise was defined as 50% of maximum perceived exertion, which is a Borg 11 through 13, and high intensity was perceived as 80% of maximum exertion, which is a Borg 16 through 18. Each exercise session consisted of 10-minute warm-up, which is 7 to 10 on the scale, a 20-minute interval exercise on a bike with allocated intensity, a 20-minute varying circuit exercise on the floor with allocated intensity, and a 10-minute cool down. Exercise intensity progressed gradually over the first 5 weeks. During week 1, the patients got familiar with using the Borg scale for adjustment of exercise intensity, and during week 2 to 5, biking, walking, and circuit exercises were introduced, and exercise intensity increased weekly until reaching the scheduled 50 and 80% of maximum respectively. Intensity remained constant during weeks 6 through 12, and volume increased substantially. At baseline and follow-up, blinded assessments were performed by trained medical personnel. Patients had an advanced echocardiography, a 24-hour measurement of blood pressure and heart rate, cardiopulmonary exercise test for measuring maximal oxygen uptake, which is peak VO2, and a questionnaire of previous medical history. The primary efficacy outcome was burden of AFib in the time period from week 4 to week 16 of exercise. It was calculated as the ratio of ECGs with AFib and total number of ECGs. The secondary outcomes were change in peak VO2 and overall hospital admissions. Change in peak VO2 was measured from baseline to follow-up, which was week 12, to assess the effect on physical fitness of low intensity and high intensity exercise, respectively. The overall finding of this controlled trial was that high intensity exercise was not, in fact, superior to low intensity exercise in reducing the burden of AFib during exercise intervention period. The difference in the effect of low intensity and high intensity physical exercise on AFib burden is smaller than expected. Both groups, low intensity and high intensity, improved their physical fitness significantly to a level comparable with patients from other cardiac rehabilitation programs. However, those that conducted this experiment couldn't confirm any clear difference in burden of AFib between the two groups. The conclusion states that during this randomized controlled trial, 12 weeks of high-intensity exercise was not superior to low-intensity exercise in reducing the primary outcome, burden of AFib, among patients. High-intensity exercise was well tolerated. No evidence of increased risk was found for high intensity compared to low intensity exercise. To maintain a healthy lifestyle, AFib patients should perform physical exercise. However, based on these findings, it is not possible to provide any specific recommendations for AFib patients, and further large-scale studies with longer follow-up are needed. Thank you.